yourself, and then I'll introduce myself, and then I'll go right into the presentation. How's that?
Sure. Tara Moffett, attorney with Gervin and Ferlazzo, and one of the co-chairs of the Capital District Special Education Regional Task Force. And my area of practice is special education law, and so I will be kind of covering both the law and some of the practical issues from both district perspective. But as Steve and I often say, I think that we're always looking at it from a child, advocate perspective, because we do recognize that there are enormous amounts of challenges with kids with disabilities and mental health issues. And, our goal, as always, as school districts, is to ensure that we keep kids in school accessing programs and services. And so hopefully this will be informative and helpful to that effect.
That's great. Thank you, Tara. Yes, Tara and I have worked, if you want to say, on opposite sides of the table, and I feel like we've done very successful things for the student and for the district. So I feel very good about that. And Tara, can I just ask how long you've been doing this type of work?
I think we're coming up on 25 years, thereabout.
Very good, very good. Yes, my name's Steve Oil. I am a credentialed family peer advocate. I am employed at Northern Rivers Family Services, and my role is to help parents of kids that have mental health issues or mental illness. The three things that I do is provide emotional support, kind of like a paradigm of a support group, even if it's just one-on-one, me and the parent. I provide parenting support when necessary, although I always tell people that, I think every parent I've ever met could pass a written test on parenting. Sometimes in my work or in their lives, it's tough sometimes to parent kids with mental health issues. I always say that wasn't in the brochure when you want to become a parent. And then the third thing I provide is advocacy. I do systems advocacy of any kind, but most of the call for advocacy I get is educational advocacy. I have a lot of training, and I've had a lot of training and a lot of experience. And my job is to try to get, just like Tara, try to help kids get what they need when they have special ed. So I'm going to let's do the next slide, please. We're going to spend time today talking about mental illness, mental health, and also about discipline and how that relates to discipline and manifestation determinations in schools. All of the mental health information you're going to see or have already seen on these slides, I stole, so to speak, from the National Institute on Mental Health.
It's called fair use. It's not stolen. When you use information that's out in the public domain, it is fair use doctrine. So you have permission.
So it wasn't stolen. Thank you for that. I appreciate that clarification, Tara.
You're welcome.
So there's the link right on this second slide. So you can go right to that website and look up anything and everything that you want. Okay. Okay, next slide. So it's interesting that this definitions that I found first: any mental illness and serious mental illness. So I think it's interesting because the words they use here in the definition is defined as mental, behavioral, or emotional disorder. That covers a lot of ground. I think it can impact and can range from being very mild to moderate or severe. And then that leads us into serious mental illness, which is also defined as mental, behavioral, or emotional disorder. But with serious mental illness, it results in serious functional impairment, substantially interfering with limits or limits one or more major life activities. So I always look at going to school as a major life activity. Okay, let's go to the next slide. So I'm not going to spend a lot of time on this. I think this makes for better reading than me going over a lot of detail. But I thought it'd be important to talk a little bit about the prevalence of any mental illness, the first definition, so kind of the broader scope. I think it's just very significant. Just the number of 57.8 million adults that are 18 or older. That was from 2021. That's an estimated number of how many people have any mental illness. I think whether you know the world's population or not, that's a lot. That's a lot of people. And then I also, you look down to the third part where it talks about young adults. Well, I'm sorry. What I thought also in the second part, that the prevalence of any mental illness is higher among females than males. I think that is worth noting, and I'll talk a little bit more about that a little bit later when we get to ADHD. Um, I just think it's important to note that we see it, we might see a lot of things throughout our day at school, out in the community, at home, and kind of write things off as to people being willful, as if like sometimes just making bad decisions all the time, uh, choosing to interfere with other people's lives in one way or another. And if you look at these numbers, there's reasons behind a lot of that, and some of it is not fully within people's control. We have to look at mental illness as being just that, mental health, mental illness. It's not people trying to be quote unquote bad kids or bad people. Let's go to the next slide. Okay, yeah, I don't want to spend, let me just look here. Yeah, these are just more stats, and it's just, I just want to make people aware of how prevalent serious mental illness is. It seems a little less so than any mental illness, but I think that doesn't surprise me. I think that we should have more people that would be under any mental illness, but there's a very large, it's 14.1 million adults were estimated in 2021. 18 years of age or older in the US with serious mental illness. Again, that's a lot of people. Okay, let's go to the next slide. This struck me, the prevalence of any mental illness, any mental disorder among adolescents. So they estimate that almost 50% of adolescents have some kind of mental disorder. So of all the adolescents that you know, it's estimated that half of them have some type of mental disorder. Not they just get a little down here and there, but they have some type, or they have some problem focusing on tasks or whatever. They have half of them have some sort of mental disorder. That is huge. And then of those with any mental disorder, any adolescents of those that they estimate, about almost it says 22.2%. So almost a quarter of them have severe impairment. So, and I'm going to go through some of the more severe impairments in a few minutes. Again, it's just, so that means if you look at those numbers, you're looking at, let's say, a middle school and high school, whether they're diagnosed or not, we're estimating we got like half that probably have some sort of mental disorder, and a quarter that have serious mental disorder of sorts. That's a lot of people. That's a lot of kids. Okay, let's keep moving. And the next slide. Sorry, that wasn't the right code. So let's talk about attention deficit hyperactivity disorder. So it's very common, and I wanted to bring it up and mention it, not just because it's common, but also that I think it's easy not to think of attention deficit hyperactive disorder as a mental health issue, as a mental illness. And it is. It's diagnosable in the DSM-5, and it doesn't present when when you think mental illness, I don't know what you think, but a lot of people might think you know, multiple personalities, or very depressed, or very, a very vernacular term that is not clinical. People use the term crazy. I only share that because people use it, but it's not really appropriate for us to use. It's also it has a lot of stigma, and it doesn't really tell us anything. But I think that's what we think about. So attention deficit is very much more defined. Okay. And I referenced a few minutes ago about the higher prevalence of females, of women having mental health issues. And it's interesting because a lot of times with attention deficit, and I don't know what the stats are on autism, which is a developmental disability, but I know that typically boys are diagnosed much more often. So it's not a clinical thing, but I think an observation I want to share is that some of this, even in our diagnostic approach to these illnesses and disabilities, is kind of, we kind of look at it from a societal point of view, or what our culture is like, that we expect boys to be, to me, we expect boys to be more active. It's almost more normal. and I think we look at them that way. We don't look at girls the same way. And I think that we look at, when I saw that there was more prevalence of girls and women having mental health issues in a broader sense, part of me couldn't prove it in court, but part of me was thinking that, we expect that girls will talk more than boys, especially as children and adolescents. And I think maybe that's why there's maybe more prevalence of it, that we see it more. Okay, let's go to the next slide, please. Okay, again, the prevalence here, this is of ADHD amongst kids. So in between 2003 and 2011, there was an increase of diagnoses by 42%. Okay. And again, males, this is right from the website for the Institute, males have consistently higher prevalence of ADHD than females during that time frame. In a broad sense, that's still accurate, I think, but this, from what the studies that the Institute was presenting on, this is what we found there. So I just think it's worth noting and being aware of. Let's keep going. Next slide, please. Okay, yeah. So I just want you to have this at your disposal. I don't really need to go over this. It's just more specific facts. At the bottom of that slide, you'll see ADHD affected 3 times as many males as females. So that we are aware of. Next slide, please. So disruptive mood dysregulation disorder, or as it's commonly referred to as DMDD. This, I forget how old it is, but it's a relatively new diagnosis. I want to guess that maybe it's been around 10 years. Maybe if Tara knows different, she can correct me. That'd be fine. But but it came out with the last DSM-5 whenever that was reauthorized.
Yeah, it was really a replacement for more conduct disorder, because they tie it to also some supplemental mental health issues, not just exclusively a conduct disorder or
Not just about behavior. Yeah, great. Thank you, Tara. Yes, when I know a kid is diagnosed with DMDD, I always think this is complex. This is not even ADHD. Sometimes, if the symptoms are not mild, but maybe focused in one area, like just lack of attention, maybe it's just ADD. It's not hyperactive. Sometimes I'm like, okay, that's complex, but we can work with that. Schools are used to that. Parents, we can teach, we can do the whole bit. But with DMDD, as we go through the definition shortly, it's very complicated, or complex, I mean. And I think that's just really important. So for me, it's not a red flag as a warning, but when I see DMDD, I'm like, okay, this is gonna be complex. We need to really look at several things going on for this youth. I want to share here, where it says adolescents, children or kids that experience ongoing irritability, anger, frequent, intense temper tantrums. In other words, they go way beyond a bad mood. It's not just the mood's change, and it's not just an angry mood. The DMDD symptoms are severe typically. They will require mental health services to be treated properly for kids to grow. And kids can grow they can grow in spite of this, but they need really a lot of wraparound support from school and out in community services and their families as well. Okay, let's go to the next slide. So let's look at the signs and symptoms of DMDD. So severe temper outbursts, it could be verbal, it could be behavioral. So it could just be lashing out verbally. It could be throwing things around or getting aggressive with people or other objects. And on average, it's going to happen 3 or more times a week. So I think that's very helpful. Again, it's not just one outburst a month. It's going to be happening often, okay? Outbursts and tantrums, they've been happening, I think, to do the diagnosis, they have to be happening for at least 12 months. That's why that criteria is in there. But I think it's important that you don't wait 12 months if you start seeing these symptoms. If you're a school person, maybe you can talk with the parents and say, we should be looking at this. It's been a couple of weeks where there's a lot of this has been going on, or if a parent sees it, I think, they won't get diagnosed with this for 12 months, but I think it's good to kind of have clinical support about what's happening. Chronic or irritable or angry mood most of the day, almost every day. Okay. And I think the key things there for me are irritable or angry. So if people are depressed, they might just be withdrawn and a little grumpy here and there, perhaps. But with DMDD, I think that irritable and angry most of the time is an important thing to be watching for. Trouble functioning because of that irritability in more than one place. So if you see it happening at home but not at school, and it's not happening outside of the home anywhere else, then maybe we're not looking at this. But when you start seeing it in several different areas, school, home, community functions, then it's kind of a heads up that we should be looking. You should be talking to your pediatrician or a psychiatric professional, social worker, or anyone else. Okay, let's go next slide. Thank you. Okay, so what are signs and symptoms? I know that there's more. I want to cover this first. So again, this is kind of diagnostic criteria. I don't think we have to go in too much detail for this. I just wanted you to have it and be aware um, of some of these things, and that it's kind of for me, it's kind of an ongoing thing, and that what I've already said, irritability and cranky and angry kind of goes on a lot. And also that it changes. This slide's important because it changes as kids get older. And that's probably true of everything, but certainly with this diagnosis, as kids get older, the symptoms change. Sometimes with ADHD, that happens as well. Not everyone, but sometimes as people, they don't have the symptoms as they get to be young adults and into adulthood. Sometimes they keep it, it's different for each individual. But for example, like as an adolescent or high schooler might experience fewer tantrums than they did when they were in elementary school as they've aged, but they might exhibit symptoms of depression or anxiety. So that's why you want a professional involved to kind of help with treatment and keep an eye on these things. And to kind of know if it's still DMDD, if it's something else. Probably with the history, it would probably remain DMDD. Trouble, kids with DMDD are going to have trouble in school. They're going to have trouble maintaining healthy relationships with family or peers, adults or kids. They're going to have a hard time in social settings. They're going to have trouble participating in activities such as team sports. So from a layperson perspective, if I could just comment on that quickly, and it's just my own observation as a person working with kids and families for 30 years, with no official training exactly. But so you might have a kid, let's say with autism, that has trouble being a member of a team or working on a team at school, with, working on a project, 3 or 4 kids. And you might have a kid with DMDD that also has the same difficulty. What I think about is especially if you already have the diagnosis, what's going to be the problem? Often what gets in the way for kids with autism is most of the kids that people I met with autism, they want to be social. In fact, I would say they all want to be social, but they struggle with the rules of social stuff, and they don't internalize them, and they don't always know how to do it, and they need practice doing it, and then they can get better. And that's kind of an easier teachable skill than it is with a kid with DMDD. They might know what to do, they might have that knowledge, but what really gets in the way is their emotional dysregulation and their moods and their irritability and the anger. So the result might look very similar, but we want to look at what is the difference when you're trying to be aware of mental illnesses. Thank you. Let's go next slide. Okay, so some signs and symptoms of DMDD. So all kids can get irritable sometimes. That's normal. That's a normal reaction to frustration. Same thing for adults, to be honest with you. Severe irritability, such as in DMDD, is like having difficulty tolerating frustration. They might have outbursts. I think this is very helpful thinking about DMD, having outbursts that are out of proportion to the situation at hand. I chuckle because I feel like sometimes even at family functions, I know adults that do that, or I've seen adults do that. But that doesn't mean the adult has DMDD. I just think it's an example we can all relate to. Maybe even our own selves. Like, boy, I was really having a bad weekend, and I blew up at the family dinner. And I was, and people, we were just talking about baseball, and all of a sudden I was screaming and yelling. And I think with kids with DMDD, we're looking for that's the kind of thing we're looking for. Like, boy, that really seemed out of proportion to please, could you just stand in line as we walk down the hall or whatever it might be. Um, so they're going to be more severe and they're going to happen more often than expected for whatever age they're at. Okay. There in the bottom part of the slide, it says, and one example, parent might tell a kid stop playing a game and get their homework done or set the table. And a typical child might be frustrated or annoyed, but they'll probably follow through and do their chore or do their homework. A kid with DMDD might get very upset and emotional and have a real intense outburst, which might include yelling, it might include hitting or throwing things. That's not typical, but in comparison to it, the other example. Okay, let's go to the next slide. And I'm sorry if you feel like we're going fast. We have a lot to cover today, so I'm going to try to just keep moving. I know I love listening to Tara as well, so I want to make sure we have enough time to cover all of it. So let's talk about anxiety. Again, occasional anxiety is a normal part of life. Many people, I think, dare say we all have worries about money or family problems, our health, our relatives, our friends' health. Um, Anxiety disorders, though, involve a lot more than just temporary worry or fear, or if we can't turn it off. I have a few friends and people I know through church that different members have cancer right now, and two of them are dying. It's very sad, and it's very not frustrating. Well, it is, but it's also very sad. And I want to be supportive, and I am, but I have to get my mind off of that and a good part of most of my days, or else I get kind of crippled by it. And I can do that. And I think that's a sign of not having an anxiety, one possibility of not having an anxiety disorder, that I can turn it off. I can do what I want to do to help. I can pray. I can reflect for a little while. And then I can go to a movie. I can go cut the lawn. I can talk with my son or my wife or Tara or my whoever it might be. But with a disorder, it's you can't do that. You can't just turn it off. And again, the symptoms of anxiety disorder will interfere with working, school, and your relationships mostly.
I think from
Yeah,
my and I'm just thinking of a couple of recent student experiences. The greatest challenge for students with anxiety is perspective. That their perspective on the world is seen through the lens of whatever their fixation is that their anxiety is triggering, and the ability to kind of move past to see other issues, it's just tunnel vision. And I think that that's probably the hardest because, we say, well, there's a test coming up, but that's next week. Let's, deal with today in class. And all they see is there's a tunnel, there's this, coming up next week and I'm not going to be ready. I'm anxious, I'm stressed, I'm not going to do it. And that's where that carries over into the school setting. And again, it's that disproportionate fixation or focus that takes away from their ability to just kind of still handle the day to day.
I agree. And I think, what's interesting about what you say there, Tara, is I think it's also indicative of typical development for an adolescent and a kid. They do often have a hard time seeing outside of themselves. The trick here, though, is to not, we don't want to stigmatize mental health or mental illness, but we also don't want to normalize the diagnosis or the symptoms. So it's easy in a meeting, whether it be with providers or a CSE meeting or a team meeting at school or whoever, to kind of try to make a parent feel better by saying, but my kid does that. And or all of our teenagers in the high school do that. And I think that, the intent behind that is good. You want people to feel better. but it isn't, it can be dismissive of what is actually happening with that child. So I always like to liken mental illness to medical health issues. So you wouldn't say that about somebody with diabetes. You wouldn't, you know what I mean? You wouldn't say like, you wouldn't say how they're feeling. If they're crashing, you wouldn't say, well, my kid gets a little tired when they haven't eaten for a couple hours. That's not the same thing. And we know that. We wouldn't say that. So we just have to be cautious about that with stigma, but also accepting what's actually happening. And we'll be talking more about that type of thing during today. Let's go to the next slide. So generalized anxiety disorder, here's some symptoms that you might see. Feeling restless, feeling wound up or on edge, being easily fatigued, having trouble concentrating, being irritable, having headaches, other physical, muscle aches, stomach aches, or unexplained type of pains. Having trouble, I kind of referenced this earlier, having trouble controlling any feelings of worry or all feelings of worry. And it often affects our sleep as well, either having trouble falling asleep or sometimes remaining asleep, like maybe sleeping for 2 hours and then that's it. I want to take this opportunity again it's really important, especially for families, to make sure if you have any suspicions about this or you just want to rule it in or out, to talk with a professional, whether it be mental health professional, your pediatrician, or both, and kind of push to kind of get evaluations done. Because a lot, I'm looking at some of these symptoms, and you could say these are symptoms of other diagnoses as well. Not all of them, but some of them. So you don't want to do any self-diagnosing. You want to get good info from professionals and move forward from there. Okay, next slide, please. Let's talk about depression. And I think sometimes if we don't think about it, we think depression and anxiety are very similar, or they're the same, or we use them interchangeably almost when we talk about symptomology. But they're different. So again, different names for depression. In clinical sense, it's known as major depression, major depressive disorder, or clinical depression. So it's pretty common, but it's very serious. It affects how a person feels and thinks, how they handle daily activities, like we've been saying throughout today: sleeping, working, going to school, eating. Again, there's some diagnostic criteria in that slide. I like to point out some of the other specific types of depression that they talk about. One, a persistent depressive disorder, perinatal depression, seasonal affective disorder, seasonal affective disorder, which is referred to as SAD, which around, at least I think it's been common maybe in the last 15, 20 years in terms of people hearing about it. And if you think about it, I know probably in the very beginning myself, I was like this too. When I first heard about seasonal affective disorder and that it's affected by lack of light and that it happens in the winter, I think it's easy for us to write that off. And that's really wrong. It's really wrong to be like, that's very judgmental, and it doesn't acknowledge that this is a real thing and that people really have it and that these things happen. So I think that's why May is Mental Health Month. It's so important to get information and learn more so that we're not judging, instead we're learning. Okay, great. Let's move to the next slide, please. So signs and symptoms of depression. Okay, I want to go through these. Persistent, I think persistent is a key word there, description. Sad, anxious, or empty. Okay, an empty mood. Feeling hopeless or feeling pessimistic. Feeling irritable, feeling frustrated or easily frustrated, I think. Restlessness, feeling like you're worthless or that you're helpless. That's, I think, one of the more frustrating things to witness, is people just don't feel like change can happen. And that's very tough to watch, and it's got to be tough to have it inside of you as well. Feeling guilty about things probably that you shouldn't feel guilty about at all. Or I think a level of guilt that is not required or healthy, or commensurate with whatever you're feeling guilty about, it's an overwhelming sense of guilt. Loss of interest in any kind of pleasure or hobbies, activities. How about, hey, you want to go to breakfast? No, I don't feel like going. And that just keeps going on. Fatigue, not having any energy, feeling like slowed down, having trouble concentrating or remembering things, or even making decisions. Difficulty sleeping again, maybe waking up too early or sleeping late. Um, Changes in appetite. I think both are common, whether you're eating too much or not eating enough. But I think a common one a lot of us can relate to or hear about is I'm not really very hungry, which can result in unplanned weight changes. Again, it can manifest physically, depression. You have actual aches and pains, headaches, you got digestive problems, and of course, thoughts of feeling suicidal or homicidal can be signs of depression as well. Let's go to the next slide. So this next slide, the first part especially, I wanted to make sure that we talked about depression can also include the following, because in the previous slide, there wasn't too much, the word anger was not referenced there. Irritability, yes, frustration, yes, but not anger. And in this slide, we're talking that it can also include, or in my thought is that it can become increased anger or irritability. And I think that's an important one because again, when people, and certainly when kids feel angry, they sometimes will do things they typically would not do. Like we respond with an angry aspect. We might verbally be aggressive. We might physically be aggressive, whether it's throwing things, breaking things, or going after someone that we feel targeted by. And I think that if we don't know about that there's depression and that it's been ongoing, whether it's treated or not, and then we get into an episode at school where a kid's angry and breaks a rule and hurts someone or breaks something, I just think it's important that we know that. Because if we don't have this information, then we just look at it as an outburst and they should have controlled themselves, and that's the end of it. So I just thought that was a really important point I wanted to bring up that can come into play with discipline and manifestation determinations. So again, depression can have you feeling restless, but again, the second part, or on edge. We've all kind of felt on edge at times. Someone's feeling on edge and they can't stop it. It's going on for days or weeks. Then it's probably a sign of depression as well. Again, becoming even more withdrawn or negative or really detaching from other people in your relationships. Greater impulsivity, increasing engagement in high risk activities, um, increased use of alcohol or drugs. People do that. Kids do that. We don't want to acknowledge that or think that, and we hope that it doesn't happen. But a lot of us self-medicate, and it's not healthy. It's not good for us. It's not going to solve the problem or make things better, make our diagnosis better. Again, isolating from family and friends, inability to kind of get your responsibilities done. For students, that's getting your homework done, that's getting to school, that's doing what you got to do in class, or any other important roles and whatnot. And, I put down here, I almost did not leave this last part in, the problems with sexual desire and performance. But I thought from an objective point of view, it is naive and ignorant to at least admit that adolescents and teenagers have sexual feelings. And whether they're in relationships and acting on that or not, they still have them. And I know this talks about, well, you see, with the sexual desire. So again, if you're a friend with someone and you know that they talk about that a lot, and now they're not talking about it, that might be an indication of there's a problem with sexual desire, And I won't even bring up performance because nobody in this crowd wants to talk about that, and that's okay. But I just think it's an important thing that it's a part of it's the part of being human, and kids are human, and we should be aware of that. Okay, let's go to the next slide. So bipolar disorder, it's a mood disorder, they say, too. People often refer to it as, the old term was manic depressive disorder, manic depression. We hear a lot, I think we hear a lot about bipolar disorder, or we see a lot of it being diagnosed similar to ADHD. Um, I think I won't read through all this, but I think the thing that happens is that people understand is there's cycles of mood, whether it be regular, like every couple of days, sometimes it's within the same day, sometimes it's very rhythmic and you can see it like over a period of time, maybe over a month, maybe over every 2 weeks, maybe even seasonal sometimes. So it's different for each person, but it's again important to have clinical support in terms of getting it diagnosed if it needs to be diagnosed, and then what do we do about it? And it doesn't, it's not just about meds, it's about wraparound activities, supports, and kind of trying to stay consistent. I don't think it's about, the old story about someone's depressed and you say, well, why don't you get up and go for a walk or go for a jog? I think that's a nice idea, but it's not realistic when you think about clinical depression. And I think the same thing is true with bipolar disorder. But I do think ongoing routines, and if that includes exercise, can be very stabilizing for people with mental health issues and for all of us, honestly. So I think you have to look at it different. Don't look at it as a fix fix the situation right now because someone's really down. Look at it as how do we make this part of our regular lives, a couple times a week or daily or whatnot. Okay, let's
I
go to the
think that
next
the
thing. Oh
issue
yeah,
with I was gonna say, the issue with bipolar is keep in mind that when you're looking at eligibility and disability, we also look at symptoms that, are in their active capacity. And sometimes there are symptoms like, whether you're diabetic, you may be in a controlled state, but then you hit a growth spurt and everything may change. With mental health and bipolar in particular, you may have many solid patches where it seems all things are going well, but there still is that opportunity or that possibility that things can shift. And it can be a very slow transition or it can be a very fast transition. But I think one of the challenges is we do have that kind of, but that's not how they present. You hear from school, and it may be that that's correct for that period of time, but we still have to recognize that with many mental health issues, it does come and go over time. In certain cases, you may be in your heightened level of, bipolar symptoms, and other times you may be in a lull or in a more controlled state, and that all is just part of the problem. My experience with folks that have struggled with bipolar is when they're feeling well, they feel so much better that they don't want to comply with treatment. They don't want to participate in medication. They don't want to use some of those strategies, and that can be when they're kind of just getting right up to the point where they're about to hit that flight of fancy and grandiosity, where not only do I not need it, but I'm going to save the world. And again, these are some extreme examples, but at the same point in time, you can see sort of that up and down roller coaster, but it may be slow and over time, and that's why it's important when looking at mental health and looking at conditions that have that episodic coming up and down. You really do need to look at the student longitudinally, because it may not be every time, but there may be part of that pattern that does factor into whether or not it's impacting the student at that particular time.
right. I agree. And in a broad sense too, just the idea you referenced about bipolar, someone's feeling very well and they don't want to take their medication because they're feeling well. That happens medically. How many times do you know people or yourself? I am not this. I always comply with my doctor's orders. But they say take penicillin for 10 days. And after 3 days you feel better and you stop taking it. But that's not what the doctor said. You're supposed to take it for 10 days. In the mental health, it happens with a lot of disorders where people, when they're on their medication, they do feel a lot better and they feel like, well, I don't need the medication. So it's really the same dynamic, but it's not, and it's really hard to get people in terms of mental health if they are of that ilk. It's hard to get them to stay on their medication, and it's tough because you don't want to see them suffer, but it's kind of again back to human nature. So we want to do what we can to help people recognize treatment is all about lots of parts, not just the medication part.
And I think that with the
Um,
treatment piece, you do also recognize the stigma issue that people often feel that, we would never think twice of if you're diabetic, then you need your insulin. People naturally, well, of course, that's necessary. But I think with some people, they feel that if they need counseling, if they need treatment, if they need medication, if they need therapy, it's an indication that somehow they are lacking or are less than. And it really should be seen as no different from any other medical problem. You need to follow the different treatment recommendations, but helping people put that into perspective is a challenge. And when you're talking about adolescents, with all due respect, they feel the world is staring at them. Like everything is about them, which is part of being an adolescent. But at the same point in time, because they feel that heightened pressure of everyone is watching me, they're concerned that people draw conclusions about what they are or what kind of person they are, or how impacted they are by disability or conditions, and they would pretty much rather chew off their arm than let anyone know that they're having any problems. So that's where, we have to really focus in on helping kids not just accept supports and services as necessary, but also to recognize that having a disability is no different than hair color, or it is just something that is part of you. It is part of your makeup. You have times where it's in a good place, you have times where it's a bad place. Same as hair. Sometimes you got great hair, sometimes you don't. But at the end of the day, it's still part of you, and you have to just accept and recognize that. And I think that also is one of the important messages for districts, separate and apart from discipline, but just in general, is to help kids recognize that a disability is simply a different approach. It doesn't mean you can't do things. It may mean you do things more creatively or from a different avenue, but it doesn't mean that it cannot be effective, or it doesn't mean that it cannot be functional. I used to have such a hard time sitting still. I was ADHD before it was a thing. But my teachers just kind of let it go. And so I would, get up and wander the room. I watered the plants. I walked the class dog, you name it. There was any task to be done, I would do it. But they just sort of intrinsically sensed that was kind of the thing I needed. And I was able to, regroup. And then after I had to kind of burst those energies out, I was able to sit down and focus. That was because my teachers were particularly insightful, but at that time you were just called busy. You didn't have ADHD, you were just really busy and super chatty. But I think as we, think about how we change just our educational presentation, I mean, you walk into a classroom and it's not 4 on the floor, everyone in lines and rows. We have a very adaptive classroom. We have some kids with standing desks, some kids with sitting desks. We have kids at tables. We have kids that have large tables. We've adapted in a lot of ways to create a more welcoming and universally designed environment. I think that we've done very well with incorporating physical challenges. I think we still have some progress to make in terms of incorporating and recognizing the mental health challenges. And, while we are still moving in the right direction, that does continue to be kind of the one line that I think we are still struggling to erase, so that we can just see, the child for the child instead of the mental health being, kind of the prevalent focus.
Agreed. Thank you. Yeah, I agree, Tara. I agree. That's work we all have to do more, better of that. Let's go to the next slide, please. So again, this is kind of diagnostic. It tells us that most of the time bipolar starts during late adolescence or early adulthood. Children can experience bipolar symptoms as well, and they may come and go, kind of like what Tara was just saying. But generally, bipolar disorder requires lifelong treatment. It really doesn't go away on its own. It can be an important factor in suicide and job loss, ability to function, and family discord. So I think, but I have a lot of hope about it. Like, I think the idea of creating your life, I feel like whatever's going on, you have to kind of acknowledge it first. Because if you don't acknowledge it, then there's nothing to accept. But if you can accept that you have this diagnosis, or we can help our kids accept that. So we have to accept it first as the adults, the parents and the teachers, and then we have to make it, like Tara was just saying, we have to just make it, it's okay. There's nothing bad about it. It's just a part of who you are, and we're going to help you figure out ways to live a great life in spite of that, or in spite of the difficulties of it. So So stigma is a big theme and message we're looking to fight. And to help our kids be accepted, we have to accept it and accept them first. So let's go to the next
And
slide.
I always
Oh,
point
yeah.
out I always point out the flip side of, certain disabilities. While on one hand they can be seen as the negative, on the other hand there are sometimes, advantages or benefits that come with it. I am still ADHD. I get more done on the average day than most humans will because I run at a faster speed and I do a lot of things. It is challenging because other people are like, slow down, wait, what are you talking about? When did you turn the page and ring the bell? I didn't hear that. So but again, in the same thing with, people who have depression or anxiety, they are, they're in tune, they're sensitive. They may recognize, and have more empathy for other people. It doesn't mean that, oh, yay, I want depression because I want those aspects. But I try to, relate that not everything about a disability is the end of the day. Sometimes it's just, part of a different discussion. When you learn a strategy to navigate, when you learn how to manage, your anxiety or your depression, that is a life skill that you can then carry over that can help you in many ways, problem solving, negotiating, balancing, organization, perspective, determining, priorities. All of those skills come from learning how to navigate your own mental health issues. And that's where I try to remember when you talk to people about having a disability, you also need to remind them that this is unique and this is part of you, but it doesn't mean you can't. It may mean you need to learn compensatory strategies or alternative resources or accommodations or different pathways, but you can still do what needs to be done. We just need to find a way to make it as effective and efficient for
Agreed. Thank you, Tara. This slide I'm not going to review, but I wanted it to be there for you to review later. Symptoms of a manic episode is symptoms of a depressive episode. I just thought it was extremely helpful and easy to read. So make sure you come back to this when we're done and just take a look at it and keep looking at it. Let's go to the next slide. So let's talk about mental health awareness. So one of the phrases, in fact, at Northern Rivers, where I work, our clinics have now we refer to them as behavioral health centers. So mental health, mental illness is now referred to as behavioral health. And I think many circles. I can't sit here and say I know it's in all circles, but in many circles. So it's kind of part of the vernacular now. As a literal person, the only problem that I have it's become bad stigma in a negative way to use the term mental illness. My only as opposed to mental health. I'm just going to share you my personal opinion on that. The problem I have with not referring to mental illness sometimes is that really describes it better. Like when I think of mental health in a literal sense, we all want to take care of our mental health. It's like taking care of our physical health. So that can be all proactive type of stuff. It doesn't, to me, if you say they have mental health issues, I'm like, well, I guess that means they've got something going on, but I don't know what that really means. Where if I think of mental illness, I know it comes with stigma, but I know what it means. It means there's some diagnosis that we have to, that is identified that we can look to help this person or be supportive of this person. That
Steve,
being
I just
said,
thought
yep.
there was a question that came up on
Oh,
disruptive mood dysregulation disorder and conduct disorder, and how does that relate to emotional disability, and can it be part of, or can it be a standalone? And I said, if you go through our regulations and the classification for emotional disability, it is, it does exclude things that are, called social maladaptive, disorder. So if it is exclusive conduct disorder, if it is exclusive to, disruptive without other factors, that's problematic, but it is very rare that there are not a co-occurring, conditions and circumstances. Most of the time our kids have more than one aspect, and the most prevalent that you observe may be the disruptive, more explosive behaviors, but it doesn't mean that that's not triggered by other, more underlying issues. Oftentimes DMDD may be an outset or a representation that comes from a post-traumatic stress disorder reactivity or, a generalized reactive attachment disorder, they're, looking to reject you first before you reject them. So, that may be where some of those behaviors come from. And so I will say that it's not, it's having ODD, having, DMDD on its own without any issue doesn't mean that you do or don't have a disability, because there's no one classification or identification or disability that's going to be determinant. But I would say that may be indicative of other factors. And that's why, when we're talking about mental health awareness, helping people understand that, the communication that comes with behavior is a form of communication. Oftentimes it's an ineffective form of communication. There are way better ways that we can communicate our frustration, anxiety, stress, or what have you. But behavior is a embodiment of, I am communicating something to you. You may not like the way I'm doing it, but instead of saying, no, I don't want to, I shove you away, or I yell at you, or I scream at you, one way or another, I'm still getting across my point, which is back. Stay away from me. I don't want to do it. I can't do it. We need to, teach other strategies, replacement behaviors. And, we also look at their challenges and limitations. And that is really where the mental health awareness can also relate to mental health supports and treatments in the school setting, and where offending behavior, while not acceptable, can at times be a manifestation of the disability. And that's really where we're kind of going to go into. Having a mental health diagnosis is not an automatic, everything is related to it, because there are many different ways things present, and you're always going to look at it on a case-by-case basis. But I think that making sure that we understand that behaviors are communication and may be indicative of symptoms of additional challenges that the student may have, is part of why we have our manifestation determination review. And I'm going to go through the legal ins and outs of it, but I think that just kind of tied back into, the question that had come up earlier, which is, what is conduct disorder, or, just bad decisions, bad behavior? Because kids with disabilities are like anyone else. They make good decisions, they make bad decisions. Kids may make spontaneously unexpected decisions. Like, I'm going to, you say something I don't like it, and I communicate immediately by punching you. Not good. That is obviously a possible problem. It could be related, it could not be. I have a harder time finding that, my anger with you because you, called me out because you're now dating my ex-girlfriend. And so I have somebody arranged to come meet up with me at 2:00, where I arrange for you to come so that they can videotape me taking you down. Not exactly that spontaneous heat of the moment, incident, but it doesn't mean that that's not indicative of that person's possible mental health processing. It's just going to be, we're going to look at that in context as we review whether or not there's a manifestation component to it.
Yes, yes. Another thing I want to point out, I said here, behavior is communication, behaviors are symptoms. I want to remind people that behavior in and of itself is neutral. So it's very easy in this field, both schools and in mental health and family support work, to look at behavior and automatically assign negativity to it. And I think what's important is we should just remember that communication, it's neutral. If I don't like what if my friend's calling me about something and I don't want to deal, I know what they want to talk about, and I don't want to deal with it, and I don't answer the text or I don't pick up the phone, I'm communicating something. I'm communicating I don't want to deal with this. And eventually, you know what I mean? So like, we all communicate through behavior every day, much of the day. Some of the behaviors that we're going to talk about aren't positive ones, or it's not ones that we want to see continue or be aggressive or whatnot. But I think it's important to remember that it's always communication, and we should take it from a perspective like that as we approach it. When I'm looking in terms of discipline, we just should always look at, and Tara's referenced this, I just want to say it again, but look at whatever the violation, the rules violation, or the offending behaviors were they part of an underlying mental health condition? And I agree with Tara. I have a passion for this work, and I have a passion for helping families and students. However, I'm always looking for information before I make any assessment on how I'm going to help a family. I want to know what happened. I'll ask parents to tell me. I'll ask if I can talk with the folks at school. I want to get incident reports or whatever, because I think it's important. And if it is something that is tied to the mental health or the mental illness, great, then we can make that case. But if it's not, then it's not. Like that happens sometimes. So that's a good way to be objective, I think. Let's go to the next slide. And Tara, I kind of lost track of what we want to do with the next slide. Do we want to run through this now, or do you want to
Yeah,
come back?
I think you can,
Okay,
let's go
I'll
through
hit.
this now and we'll kind of tie it, and I may
You'll
reference
tie it
back
in.
to it when I go
Okay.
through my.
I'm looking at the clock. It's almost 1 o'clock. I got a minute away, so I'm going to go through this relatively quick. So let's these are just some examples I came up with through experience where conduct could be a manifestation of a student's disability. So let's look at if the kid has ADHD, let's say if they had a disproportionate reaction to interaction with a peer or an adult. So they're yelling or knocking items off a desk, or they're shoving or pushing or striking at someone who like bumped into them. Um, or if they're taking items from someone else after the request was refused. This could be part of ADHD. So we have to look at exactly, so those are kind of a lot of examples. What I'm looking at typically is the impulsivity, and especially if we had information that we already know this child is impulsive much of the time. And for what it's worth, I might be looking at the time of day. If everyone at school and the parent knows, hey, they're great from 7 to 12, but their next med is not given until 3, and the meds work very well in this case. So the afternoons, we see more of this type behavior. Then I would want to look at that and see what time the incident happened. Let's look at DMDD. Extreme explosive reaction, highly disruptive conduct, such as screaming obscenities, cursing at a teacher, running out of the room, severe temper outbursts. That might be related to an underlying disability. It might be related to DMDD. And again, because if you're thinking back to the slides we had before, like this highly disruptive conduct could definitely fit the DMD scenario, especially if it's like a middle schooler, because we're like, I would expect to see that type of behavior from a 6-year-old or a 3-year-old, not from a 12-year-old. So we want to look at that in that scenario. About anxiety. So let's say a student refuses to engage in their work, or they're avoiding their work. In Tara's example, maybe they're just wandering the room, but they wander the room for the whole class period instead of after 5 minutes sitting down, assuming a teacher would allow that. Or if they panic and they feel overwhelmed, or if they're crying, and they might have some really extreme emotional responses. That might be related to anxiety. Okay. Depression. If a student is repeatedly falling asleep in class, or isn't able to start tasks or initiate tasks. If the teacher says, okay, you know what you're working on, you got 20 minutes to do that now, then we're going to talk about the lesson. And if they can't get started. They've got their laptop or their Chromebook and they've got their notebook, but they just can't get started. That could be a sign of depression. Again, if they're easily distracted or inattentive, maybe in a non-hyperactive way, but still inattentive, avoiding demands, very emotional, or refusing to do work, or is just disengaging. That might mean that the student's depressed. For bipolar disorder, it might be excessive dysregulation. Again, really, really big mood swings, maybe throughout the day. Lack of safety awareness. Remember that they might take risks at a higher level than a typical teenager might. Or destruction of property. And one indication for me is always like, boy, if it's their own property. So it's easy to kind of say, well, if they're breaking the school's property, they don't care, maybe. It's easy to make that judgment, whether it's wrong or right. But if they're breaking their own thing, especially if it's an electronic device that they really like to have, that could be a sign of, that destruction of property might be part of a bipolar or some other mental health issues. Laughing or inappropriate emotional responses. for mood disorders, and bipolar could also be indicating kind of like a manic episode. So, okay, I did that in a couple of minutes. That's pretty good. Let's go. You have to add to that, Tara, or should we just move on?
You have one more slide. No,
Yeah.
I'm
Oh,
gonna,
no more slide.
I'll
Okay.
comment on them in the context of
Okay.
the reg.
So what, next slide. So the main strategy when you're looking to find manifestation or advocating for, if I'm looking, I want to make manifestation, I want to make this related to the disability. I want to look at the facts. And when we're conducting the review, you want to identify a connection with the student's behaviors and their symptoms of whatever their mental health issues are. And you also want to make connection to the student's IEP and their programs and services based on that. What we know about them from evaluations and observations, I would think both in school and out of school, if it's accurate to the student, and any prior behavioral history. So it gives us like patterns. I referenced that a minute ago about a simple one is with ADHD. If we know this student's impulsive, and that's a very common symptom for that student, then if that student gets into a fight, I am going to look to see what happened right before the fight. Like, and I want to establish. I'll tell you a fast story. There was a student that we had manifestation determination for, and he was impulsive, and he went over him. I think he hit a teacher, which was not okay. It's not okay hitting a kid either. And he hit a teacher and got suspended. And he said that he saw the teacher holding up the other kid, which wasn't exactly the case. The teacher was not doing anything inappropriate, but was with this other student, and this was the student's cousin. So the student went up to the teacher and popped him. So in the manifestation, I asked questions of where was he standing, how far away was he when he saw his friend and the teacher, and he was about 2 yards away, about 6 feet away. He turned a corner in the hall, and they were there. And then I said, "And what did you think when you saw them?" And out of the own kid's mouth, without any coaching, he said, "I didn't think." I said, "What'd you do?" He goes, "I hit the teacher." So we found in that example, the committee found for manifestation that it was a result of his disability, and that he was impulsive, and that we knew that about him. The tricky thing there is, I don't think that's we made sure the student knew that we're not okaying what he did. We're not saying it's okay. We're just saying that we understand why it happened. So anyway, I'm looking for stuff like that. When you're advocating for manifestation, you want to make all those connections. And I think that lands it for me for now. I think we're going to turn this
Mhm.
over to Tara.
Okay. So I'm going to just sort of do a quick review for discipline, and then we're going to talk about where it deviates for students with disabilities. And the reason that you need to understand it is to understand that we're going to talk about two different segments of discipline. One is discipline for everyone, which is how kids will be treated, disabled or not, for the first 10 days, and what laws and provisions apply to that. And then there's discipline and protections for students with disabilities, which go into effect if there's a disciplinary change of placement. So I'm going to kind of cover all of these different provisions, and then we're going to, walk through it. So next slide, we're just going to jump through very quickly, is, Education Law 3214. That's New York State education law. And it basically, requires that children who are going to be subject to any kind of discipline, and there's a range of discipline, have certain procedural rights, and the number of rights and the amount of protections really depends on what the kind of discipline and what the duration of discipline might be. So ranges of discipline can be everything from warning and a talking to some sort of a community service activity, all the way through to in or out of school suspensions and a short or long-term suspension. But there should be what we call progressive discipline, because not every incident warrants the same response. And it also should be considered based on the age and the nature and the developmental aspect of the child, because, again, how you would respond to a child, shoving another peer when they're in kindergarten may be a little bit different than the response we might have for a high schooler who decides to shove another peer. There's a difference in terms of developmental and understanding and communication. So basically, if it's something that involves, a suspension, because the remediation, counseling, calling and talking to your parents, doing meetings, and all of those other aspects, restitution, detention, that doesn't impact your ability to access and attend your program. It may take you out very briefly, but typically that's not going to have a significant impact on your education per se. It's the in-school suspension, out-of-school suspension, and longer-term suspensions that are really going to be where you might have the most, significant impact. And that's why there are additional procedures and rights that are afforded. Anything that involves a suspension, out of school suspension, to be clear. Some districts do an in-school suspension notice, but you must do an out-of-school suspension notice. That can be imposed by a principal or a superintendent or a board of education if you're a very small district. Sometimes you have the principal and superintendent are one and the same. And so if they issue one suspension, the board might issue the other, so that you have like a different person making the decision instead of having the same individual review that. If there is a suspension that's being proposed, and again, it's supposed to be something that's proposed, is, we notify the parents, we notify the student of the reason why they're, potentially going to face discipline. And we will typically, send written notice to the parents and the student of the proposed suspension before it is imposed. Or it'll say, we are prepared to suspend your child starting tomorrow at such and such time for the next 3 days. And in that notice, it's supposed to give you information about the right to an informal conference with the principal to discuss the proposed suspension and to question complaining witnesses. Why? That's the opportunity to, have your child or you present information and, to attempt to alter or to get the principal to review and consider if they had all of the facts, did they have all of the information, would that impact their determination if something new came to light. Such as, the student, yes, had an incredibly horrible day, but I didn't get a chance to call you and it happened so early in the morning, but their grandmother, dog, friend, something horrible just happened. And I should have, called right away. I didn't, but that's really what was happening. The principal might say, this was bad and problematic behavior, but I hear what you're saying and I may not want to, throw the book. So they might amend or alter their decision. There's only one exception when it is a short-term suspension that the suspension can be imposed immediately, and that's when it's determined by the principal or the superintendent that the student's continued presence constitutes disruption and an immediate threat to the safety. And there's not a ton of those, but for example, where that has been deemed necessary is we had a student who posted online that they were bringing weapons to school. They came into school, they were immediately, brought in, searched. They in fact did have a weapon. They were, the weapon was turned over, they were removed. That was one of those instances where the superintendent, or not the superintendent, the principal determined there was an immediate discipline. All it means is you still have to follow the notice requirements. It just means that you might implement an immediate start to the suspension instead of waiting till the written notice is issued. During any of those suspensions, the student also should be, notified or receiving alternative education instruction. Sometimes if it's a one-day suspension, by the time you've got arrangements for tutoring, they may already be back, but there is still need to do that because we, do not want to deny the student the right to instruction. And that's a part of that process. Can we go to the next slide? So the alternative instruction, and this has, changed as of the current school year. And originally there was a question as to whether or not the alternative instruction mandates that changed effective July 1, 2023, included discipline. And the answer is yes. So if you are elementary, you are entitled to 2 hours of instruction daily. And if 3 hours of instruction for secondary, which is usually middle or high school, depending upon where your grade level in your district changes. Some it's K5 is elementary, some it's K6. But it's basically 2 hours for elementary or 3 hours for secondary students. And that's something that should be arranged. That's for the first 10 days. And it doesn't necessarily include special ed or related services because you treat these students the same as a non-disabled student. It doesn't mean the district could not elect to arrange and provide those other services while the student is out on a short-term suspension, but it's not mandated. However, you should also receive notice of the right to appeal, even a short-term suspension. And that's just to let the parents and, the student know that if they disagree, they can appeal. One of the challenges with a short-term suspension is typically the appeal process lasts longer than the actual disciplinary removal. But if it ultimately is determined that the suspension shouldn't have been imposed, then you can request and seek expungement, meaning have that removed from the student's record. So there is still the possibility of that appeal. Okay, so that's kind of the basic up to 5-day suspension. Now, next slide, we're going to jump into our suspension for anything more than 5 days. So 5 days, you get written notice, the opportunity to meet with someone, and that's pretty much the process, alt ed, and the right to appeal. When it comes to any suspension that's going to be 5 days or more, you get additional protections. And that's because it has a longer impact on a student. It's not a 1, 2, 3, or 4-day suspension. It's something that can bring you into a second week. It can have a much bigger impact. And because of that, there is a higher level of review and a higher level of expectation. So instead of a single person, the principal, making that determination, it goes under a review. So this is where the district has to present a written notice of charges, meaning, what is it that the student is accused of violating the code of conduct? And if we are, proposing a suspension beyond 5 days, and that's usually when you go to a superintendent's hearing, whether they got a 5-day suspension by the principal, you're saying, I'm looking at something beyond 5 days. And so that's going to put you in front of a superintendent or a hearing officer. And in addition to receiving notice of the charges, you get notice about certain rights. And that includes the right to a fair hearing or an impartial hearing, not in the special ed sense, but this is in front of a hearing officer who's going to review information and witnesses and testimony and evidence and determine if the district has, established that the student engaged in misconduct. And then, there's also the, different phases of the hearing. First phase is determination of guilt. And at that point, you can't consider prior discipline history. The only thing is, does the district have the ability to demonstrate the student engaged in this misconduct based on our evidence, our witnesses, our testimony, or even a student's admission? In some cases, the parents and student agree, yes, they did it, but we still think it's because of disability. And we'll come to that point. If there's an admission and the parent and student want to waive the right to a hearing, which they can do, they just need to be on notice of their rights. And those rights include the right to, review the charges, to review evidence, to present witnesses and testimony, to cross-examine witnesses that the district presents, and to be represented by counsel if you want to arrange and bring one. If the student is found guilty of one or more of the charges, then it can roll into a second part of the hearing, which is, if we go to the next slide, the penalty phase, where this is the definition of the guilt phase. And it's basically the district is the one that has to prove it. The student doesn't have to prove that they didn't do it, although oftentimes parents and students will establish that, it wasn't me, you misunderstood, that wasn't what happened, I have different facts. But the hearing officer or the superintendent is going to make that decision. And if they find them guilty of none of the charges, then that's the end of discipline. And the student goes back, and that is, the conclusion of that process. On the flip side, if they find the students guilty of one or more of the charges, then there is the possibility of additional penalty. And only after you have made that determination of guilt with respect to the charges that are being alleged in this incident, can you consider any prior discipline history when you are, reviewing a penalty. But what you can't do is say, well, they've done this before, so therefore that's evidence that they've done misconduct again, or in this case. Each time, that is an independent determination, and it's based only on the facts that are presented to the hearing officer or the superintendent at that time. And again, you still have all of the rights. They can present witnesses. The student could choose to testify. The parents can, ask questions, not have the student testify, either or. But the district is the one that bears that burden. So next slide is the penalty phase. Okay, penalty phase is if we found the student is guilty of one or more. Typically for a non-disabled student, it's going to roll right into the next phase, which is that point, the administration may present information about the student's prior disciplinary history saying, this is what they've done previously, this is what they did now, and this is why we're recommending more than a minimal suspension, because we feel that this is a high level of problematic behavior. It created a safety issue. It created a threat. It's not the message we, want our kids or our community to have. For example, people who are vandalizing in the bathroom and, drawing swastikas, real life story, horrible thing. The district wanted to really make sure that that was addressed, and that, they did not feel that, I'm sorry, I shouldn't have done it, or I should have thought it through, was enough of a penalty, particularly given both the reaction and also, just the inappropriateness of that message. So sometimes they will go back to that point. They'll look at prior discipline and they'll make a recommendation. If it's a hearing officer, they make a written recommendation regarding their findings and a proposed discipline that the superintendent then considers, and they can adopt it, they can amend it, or they can, reject it and impose their own based on their review of the records and the hearing. All hearings are recorded, whether it's auditory or whether it's, video recording. They must be preserved in the event of an appeal. And so it's always sworn testimony, but there is a record created. There has to be a written decision. Sometimes they'll give you an oral decision the day of the hearing to say, I'm going to recommend continued out of school suspension, and you'll receive my written decision shortly. But the written decision is supposed to explain how they reached the determination, what the conclusion was, and provide notice of the right to appeal to the Board of Education, and then possibly to the Commissioner of Education if you disagree with the determination by the board. So you still have procedural rights, even beyond the right to a hearing. It all depends on whether or not you disagree and whether or not you want to file an appeal. As with everything, if the student is still subject to disciplinary removal, they should still also get alternative instruction. And that's because we recognize our kids are going to come back to school at some point. And the last thing you want is for them not to have continued to keep up, because discipline is not supposed to become the roadblock to the student's success or performance. It's just supposed to be, a recognition of this is the consequence for the violation of the code of conduct that goes beyond what we thought would be an appropriate building level discipline. If there is an appeal, then that is, going to be subject to the determination, and sometimes those appeals will be founded and they may reverse. Other times it will not, and the student may serve the entire suspension. If they have completed the suspension and then the determination is made that it is no longer, that they shouldn't have imposed that suspension, then there may be an expungement, meaning just they legally remove that reference from the student's records or files. But you can't really kind of go back and unring the bell if you've already served the suspension. So next slide is where we get into our differences for students with disabilities. So pretty much we follow the same process I just outlined for every kid between first, the 5-day suspension, building level, rights to notice, rights to info. If you're going to a superintendent's hearing, right to additional procedural protections, right to a hearing, right to the phase of presumption of innocence until you've gone through the guilt phase. If you're found guilty, then and only then can they talk about any prior discipline and imposing, and you still have rights to appeal from that determination. For students with disabilities, our magic number is day 10. So, and that's where we're going to talk about what constitutes a disciplinary change of placement, what is required for a manifestation determination, there are a number of different instances where even if it's deemed a manifestation, we find that they are so egregious or so unsafe that we really recognize that these are situations where that student may need to have a penalty, even if it is, directly related to their disability. And oftentimes those 45 days are used, or up to 45 days may be used to try to work something else out, because we need to address the nature of that problematic behavior. And then we're going to talk about what the interim alternative education setting is. So instead of just alternative ed, which we give to all students, we with kids with an IEP will get IAES, which goes, consider it like alternative education plus, with extra muscles for kids with disabilities. So we'll jump to the next slide and I'll start to walk you through. So for the first 5 days, 10 days, you follow the same process. Everything's the same. It's only when we are going to come to what we call a disciplinary change of placement. Disciplinary change of placement can be gotten to because you have 5-day suspension and then you go to a superintendent's hearing. So you're probably going to get to 10 days, and that's a quick time that you may end up back at a manifestation determination. Other times it may be smaller. I got a half-day suspension here, I had an in-school here, I had another, half day there, I got a 3-day suspension, a 2-day suspension, and now I'm going to a superintendent's hearing. Whenever you have either individually or collectively a pattern of removals, or consecutive days that can get you to a 10+ day of removal, that is when we have a disciplinary change of placement. And you take into consideration whether it's a disciplinary change of placement, the similarity between the conduct, the length of suspension and removal, the total amount of time the student's been removed, the proximity of suspensions and removals to one another. Could you have a child who's removed for more than 10 days in a year where it is not a disciplinary change of placement? Technically, yes. Would I say as a district council that I would say roll the dice and run with it? Nope. I'd say do a manifestation if you're going beyond 10 days, and that's the better, safer action. I do know that there are some people who might take a less conservative approach, but for me, I'm always of the mindset I'm going to meet that they need to, think that through. If it is determined, typically it's going to be by the suspending authority, the principal or the superintendent, that this would constitute a change of placement. Then we have additional rights that will attach to the student with a disability, and that is, next slide, dun, 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 the right to next slide. Uh-oh, the baby may be distracting her. Okay, right to a manifestation determination. So manifestation determination has to be conducted each time a student is removed for more than 10 days or there's a change of placement. Once you get to 10 days and you've had your first change of placement, after that, anytime you have additional discipline, it's a change of placement because you're already at 10 days. It's 10 days in a calendar school year. So there's no, it doesn't reset and you go back to 0 and you start all over. It's going to be it's going to require a manifestation, or it's going to be a change of placement, after that. And the manifestation is conducted by relevant members of the CSE, or in cases, the 504 team, as determined by the district and the parent. Most of the time, it's going to include a psychologist. Why? Because chances are high it involves behavior. It's going to involve, if the student has a special ed teacher, probably they would be involved. If the student has any integration or gen ed, usually there may be a gen ed teacher. Obviously, you're going to have a chairperson, and then it may have others who have knowledge and expertise about the student. It could be the student's counselor. It could be, their speech and language provider. It might be, a building administrator who's been involved in a lot of the, the background and info. The manifestation determination review is conducted by going through information that we have on the student, and this is where kind of going back to what Steve and I were talking about. Understanding the nature of the student's disability is part of making sure that you have provided as parents or as advocates the right information about the student. And I would say that, this is where sometimes people are reticent or they fear stigma and are less inclined to disclose, saying, well, they don't take their meds at school, so no one needs to know that they have these mental health issues. That may come back to, have an adverse impact on you, because if we're treating this as a student who has, a language impairment and has no idea that there's any mental health issues, we, one, aren't probably providing any mental health support, and two, that wouldn't be reflected anywhere in the IEP that the student has, those needs or may require additional support. So we look at, as a manifestation team, you look at the relevant info in the file. That's your IEP or your 504 documents. Teacher observations, reports and evaluations that are in there, relevant information from the parent, and information about the underlying incident, because that's what you're basically determining. Is this a manifestation of the student's disability? Can you take into consideration information that comes in after the fact, things that are handed over, day of? And we, as school districts, I've seen, we get a note from a counselor that says, oh yes, this is definitely a manifestation. And we sometimes get notes from psychologists saying, we really don't feel that the student understood. It's important to understand what our two questions are, because a lot of people are still operating under the impression that the two questions the CSE asks have to do with, did the student understand the consequences of their action, or was the IEP being implemented? And if not, then it's automatically a manifestation. That changed back in 2004, but there are still some people who, kind of use the older standard. There was a lot of advocacy and there was a lot of concern about school safety in the late 90s and into 2000 because we started having more and more issues with gun safety and school threats and, school violence and Columbine and horrible things that were happening. And because of that, they said, we're running into a situation where kids with disabilities who may on occasion do very unsafe things are having no consequences because everything's a manifestation of their disability based on the standards that we're having. And it really should have, it's got to be the real disability is the underlying issue and not just, well, I have a disability and someone forgot my OT. And so because I didn't get an OT session and I may have smashed through a window and, punched two people, it's a manifestation because my IEP wasn't being implemented. So that was where, that's an extreme example of where things were disproportionate. There are also times where, it was a manifestation and people may have struggled with that determination as well. End of the day, they said, okay, we are revisiting the issue and we're going to ask two questions. One, was the behavior that directly resulted, that resulted in the conduct that brought the student to face a penalty directly and substantially related to their underlying disability? Yes or no? Or was the behavior that resulted in discipline the direct result of the district's failure to implement the IEP? So I usually give the example for district staff that, if the student has an IEP and they have a one-to-one aide whose job is to give the student breaks and to, provide redirection and reinforcement and review social stories and provide some of these strategies, and that aide has been out and they didn't have coverage, and then the student has, a very challenging day that involves an explosive meltdown and aggression or other issues, that might be considered a manifestation due to the failure to implement the IEP because they were lacking that critical service and support. On the flip side, this was my favorite creative solution. One of my friends who represents kids had come in with a student with a learning disability who, in the area of math, who was selling pot brownies. And she wanted to argue that obviously they were being, entrepreneurial and they were using math. And I said, no, that doesn't constitute one. You're in the 45-day exception because you got, pot brownies. But I said, but in the future, if he's interested in the culinary arts program, let me know. So we put that out there, but it really has to be substantially indirectly related, not that, well, it could be because we hear in part that some kids with this, condition might automatically do this. We look at how does that condition present with that student. And I give the example of ADHD because, ADHD has many, many faces. There's, the Energizer Bunny nonstop that just goes, keeps on going and people can't keep up. That one's kind of the my zone. There's also, Pigpen for anyone who doesn't know what that is. It's Peanuts characters, people. Come on, read up on stuff. But for those who have lived in the world where, some of those references are too old, let's just say you're disorganized. When you open your locker, all of it falls out. Your book bag is, the Bermuda Triangle. You never really know where your stuff is. Your shoes are somewhere. You lost stuff. You're very disorganized. Does that ADHD represent the same as the Energizer Bunny HD or the other kid who literally is like itchy in their skin and can't sit still and is constantly in motion and racing around? Each of those are three different presentations of the same disability. So it really goes back to what are we looking at and how does it present for that student? And that's where making sure that we have a good understanding of the student and how the disability presents in them. And that's when we review those IEPs and programs and services, you determine, is it a direct and substantial relationship to the underlying disability that we have? So we're going to go to the next slide. And, just to clarify, it doesn't mean that, if it's not part of the focus of your IEP plan or your 504 plan, well, too bad for you, we're done. So not a manifestation, good luck. It means that it may be something we need to get more information on now that we know about this issue, and we may need to factor that into, the IEP going forward. It might not be a manifestation at this time, but we certainly are going to look at that. On the flip side, it might be, yes, this is a manifestation. If it's a manifestation, 9 times out of 10, that is the end of discipline. There's the limited exception of our 45 days for possessions of drugs, weapons, serious bodily injury, and I'm going to cover that shortly. But for the most part, that's going to be, the student is then returned to their program if it is no longer, if it's not, if it is a manifestation, then they go back to their program. But we also recommend that the CSE review and address issues that will try to prevent that from occurring, such as a behavioral intervention plan and an FBA if they don't have one, or review the existing plan. Do we need to do something different? Look at the programs and services. Do we have enough support? Do we need to look at different support? It's important to note that parents and districts can also always agree to a change of placement to the student, having, even if it's a discipline, even if we find it's a manifestation, but we realize this is not the right fit for the student and we really want something different, the disciplines ends, the student can go back, or alternatively, the parents and districts can say, maybe we want to do something different, or maybe we agree that, right now, mom and dad are saying, my child's undergoing a whole medication titration. The psychiatrist is working with them. We don't know how they're going to respond. We just saw what they did this week. That's not their typical. Can we keep them home on tutoring, give it 10 days, 2 weeks, and then see where we're at? Yes, we can come to those agreements. That's not a discipline change of placement. That's an agreed upon change of placement. And I think I encourage parents and districts to work together on, sort of navigating the unknown until we have that child at a stable point, and then try to reintegrate them either back or say, yes, we need to look somewhere else. That's when you're, able to come to that. If it's not a manifestation, then the student may still be subject to discipline. Typically, when you're doing it in a superintendent's hearing process, you go through the guilt phase of the hearing. If the student admits or they make a determination that the student is guilty, there's a break. You go do the manifestation, because you don't need to talk about penalty. If it's a manifestation, then the discipline typically ends. On the flip side, if it's not a manifestation, the other job of the CSE is to recommend what we call an IAES, interim alternative education setting, which is basically what is the student going to get to allow them to continue to make progress towards their IEP, as well as to access their goals and make progress in the curriculum. That's a decision that the CSE makes. At a minimum, it's got to be the 2 or 3 hours of instruction, plus whatever else the CSE deems as necessary. So if you have related services, if you have counseling, if you have, consultation, if you need access to certain devices or tools, that may be part of what we recommend as part of the IAES, because our goal is to make sure that it may be a different setting, but you're still going to continue to have access to your IEP. Okay, next slide. There are the 3 exceptions, and I have them legally defined underneath here. These are directly from the regulations to help you understand that carrying and possessing a weapon at school, on school premises, or to a school function is pretty straightforward. We understand that that's dangerous. It's problematic, it's unsafe, and that's a pretty clear violation. So even if it's a manifestation, the student may still be subject to discipline. The superintendent or the hearing officer has the authority to impose up to a 45 school day suspension. Authority to impose does not automatically mean that they must do that. And there's always the discretion to take into consideration the developmental age of the child, the appropriateness of this prior discipline. I always take into consideration student, contrition, and are they recognized or remorseful? Did they seem to recognize why this is such a significant issue? But if you have, people who are really, yep, I did it, I'm going to do it again next chance I get, we'll do that. We also have, when kids are bringing weapons or have threatened to bring weapons, we sometimes as school districts will go through the emergency order of protection and removal order to address if there are firearms or other weapons in the home. And that's something that districts have had to use more just as a added protective measure. That's not in every case, but where there is a realistic possibility of weapons coming to school, that is something more districts have had to use. And I will say, sadly, we've had to do it much more often than I'm really comfortable with. I would say last year we had, I think, 13 or 14 emergency orders. The year prior we had fewer. This year to date, I think we're already past 14. So it's problematic, but working through. Inflicting serious bodily harm is a very high level. Why? Because they borrow it from the criminal law. And so you have to, have bodily injury that involves risk of death, extreme physical pain, protracted and obvious disfigurement, protracted loss or impairment of the function or bodily member, organ, or mental faculty. The way I put this for districts, broken bones, concussions, uh, you know, hospitalization, serious, protracted pain. It's not, a bump, a bruise, or a scrape. Not to in any way, minimize the seriousness of someone being harmed, but it was really intended to be for a very significant level of safety, risk, and harm to individuals. And there's another option which I'll cover, but that's why it's not used frequently. I've had thinking about 12 cases that met the serious bodily harm. Almost all of them involved both concussions and broken bones, or one or the other. Knowingly possessing, illegal drugs, or using and selling and participation with solicitation of illegal drugs. That's another one of those very unsafe. And again, they have the ability to impose up to 45 days, but it's still a discretion. Oftentimes where it's, the latter, where it involves, drugs, we may also be looking to try to partner with the parents to get, the child into some other treatment programs, and what are they doing to address the substance abuse, and, working towards trying to, holistically address that. And it may be, as Steve had talked about, some of those co-occurring, medication plus disability plus decision making may make for a very poor partnership, but we work our way through. And so even if it is a manifestation, there are times where students may be subject to disciplinary removal, but they will still continue to access a free, appropriate public education. Okay, next slide. So IAES, as I said, it's what I call, it's your minimum of 10 hours or 15 hours based on the age, plus whatever else the CSE determines is necessary to allow the student to make progress and to access the curriculum and to, meet the goals, plus to receive as appropriate an FBA and BIP. If you don't have a functional behavioral assessment and the student is, disciplined for behavior, there should be discussion of doing an FBA and a BIP. And if you determine that they do need the behavior intervention plan, those targeted strategies should be there to address and prevent the student from engaging in that kind of behavior and repeating that behavior again. Okay, next slide. We're almost to the end, so hang in there. So importantly, after you've done your manifestation determination and recommended IAES, if there is a finding of no manifestation and therefore the student may be subject to discipline, or it's manifestation but one of those 45-day removals, you're going to get written notice of the determination and how the committee came to its decision. You should get, at least for the first manifestation determination in the calendar year, notice of the procedural safeguards, including, notice of your right to mediation, to due process, to, state complaint, and, pendency. If you challenge there's a pendency provision, which will come up in one more slide. But basically the written notice is to make sure that the parent is aware of the outcome and the decision, and also to advise them of the right to challenge or to appeal. You will also get the notice of manifestation when it is a manifestation, but in most of those cases, parents don't pay a whole lot of attention because they're like, yep, it's a manifestation that goes in the pile of papers, because I don't disagree with it. It's usually when there's a disagreement, people read them much more carefully and they want to look through it. Important to note, there are two processes for appeal. If you disagree with a superintendent's decision or a principal suspension, that gets appealed through the superintendent and then the Board of Education and possibly to the commissioner. Anything having to do with a superintendent hearing or a building or a principal or a superintendent suspension. If you disagree with a CSE, manifestation determination, recommendation of IAES, determination regarding the appropriateness of program, that's a separate appeal or challenge through due process or mediation or a state education department complaint. So you could potentially have two different appeals that go from the same disagreed upon disciplinary incident and consequence. But it's important to understand both of them have different timelines and both of them happen, could be happening simultaneously. There's been a number of different, cases where parents appealed one but didn't address the other because they thought, well, if I appeal because I disagree with the manifestation determination, this, that's going to reverse that hearing officer decision and my child's suspension and removal. Nope, got to make sure you do the proper appeal for both processes. So that's just kind of a general reminder that there are more than one method of appeal. Why? Because 3214, that education law that covers discipline and removal, applies to the world. IDEA only applies to kids with disabilities. So you have two different sets of rights. Okay, next slide. If you do find manifestation, then typically that's going to result in, the student returning to their prior program, and they'll do an FBA or a BIP. But except under special circumstances, once you find manifestation, that child has the right to go back. That doesn't mean that the parent and district cannot come to some other agreement or decision that, we don't really want to put them back because we think that that's not the right fit. But that's not discipline. That's an agreed upon change of placement between the parent and the student. But these are just basically the explanation about pendency, and special circumstances are 45-day exceptions, where even if it is a manifestation, it's such a serious nature of a violation that they have the right to return. Okay, next slide. So there was one other I alluded to, if it's not serious bodily injury and it's not, one of the other 45-day exceptions, but we do believe that maintaining that student in that program is, substantially likely to result in injury to that student or others because they have had a historical pattern of unsafe behavior. It may not rise to the level of a 45-day exception, but it's repeated and it's extreme and it's unsafe, where we've had, certain incidents where kids are literally, pounding upon staff or other students, or, have broken window after window and everything. It becomes, a safety issue because there's only so many times you can, clean the windows and break it down. And again, this is rarely used, but I will say, I always said that I, had previously said I've never had to do it. I've now had to, initiate hearings for an IAES 5 times. Where we really believe that the students' safety was, that their continued presence was a threat to themselves and to others. In many instances, going forward and beginning that process and filing helps parents and others understand the seriousness of that offense, and it doesn't ever stop. And Steve's sort of nodding at me because he's one of the ones that I had this with. We understand that there are still other creative solutions that can be done. But if we don't have agreement with the parent and the student is, otherwise going to go back to that same program, to those same circumstances, and we really don't feel that there is a, way to maintain that safety, that's when a district might request a removal by the hearing officer to an IAES, which is basically going to be that, at least the minimum of 3 to 4, 2 to 3 hours of instruction plus related services. But it's really to give the parent and the district and the team time to figure out something else and hopefully to come to an agreement, because, we do believe in those circumstances that child's presence can be very, very unsafe and very dangerous. And again, most of the time, I don't feel like we get to that IAES order because there hasn't been a lot of communication. It's usually there's been a lot of communication, but we are just not on the same page. And in some cases, we've done the IAES order because the district has said, we need a psychiatric and you haven't agreed to it. We need the functional behavioral assessment. You haven't agreed to it. We really need more information. You won't sign releases. We don't have any other option, and returning the kid and expecting this to magically resolve is not working. And so we might go to a hearing, and some of that is to actually secure an order from a hearing officer to secure the right to do an evaluation over parent, without the parent's consent. It doesn't mean that the outcome of that decision or the outcome of that determination is going to change things, but it just gives, access to what we believe is relevant information. Again, very rarely used, but I wanted you to understand, because sometimes people will be like, well, if you really thought it was dangerous, you would have done something. This is the thing that people can do if it doesn't meet a 45-day exception, but we have repeated and extreme behaviors. I will tell you, as an attorney for, working with school districts, I will look very carefully at the level of, documentation we have for, the safety issue. And, I will oftentimes say, look, there's, you're right, these are some unsafe behaviors, but I'm not seeing that you're reaching that level. And then in other times I've said, yeah, wow, we're filing. We need to do that. And, that's a rare exception. And like I said, I used to say I'd never done it. Now I've done 5, which is, not where I want to be. I will say only one of them went forward. The other 4, we were able to eventually work stuff out. But it's an important thing to note that that is one of the reliefs or the resources that are available to districts. It's rarely used because it's still an adversarial process. And it's also under a very tight timeline. You have to get this done in 20 calendar days with a decision 5 days following the end of the hearing. There's no adjournment. There's no extension. It's just go, because it's saying basically, because we're removing the student or getting a hearing officer to remove the student without the same level of process, because the hearing officer has to agree, yes, I find that that student's continued presence is that much of a safety issue. And they can potentially also renew that after the end of the first 45 days. They could potentially get another 30-day renewal. Again, still has to have that showing that their continued presence is a threat to health and safety. It is not where anyone wants to be, and oftentimes we, are usually able to work with parents, with the mental health providers, with the team to try to figure out how do we fix this, because no one wants the child to be unsafe, no one wants the other, students and faculty and others in the school to be unsafe. But we do sometimes have to get to that point where we need to use the legal resources that's there. My favorite preference is always working collaboratively with parents and with the district to find a mutually agreeable solution, because litigation to me is, it means that our conversations have often ended, and it doesn't, really help, because our goal is always to be able to work collaboratively and to keep going. Okay, next slide. These are just a bunch of questions from really helpful guidance that the Department of Education put out in July 2022. I called that the Summer of Discipline, where they issued tons of guidance on proactive measures, resources. These are some of the more common questions that people raise about, what do we need to do to support kids with disabilities? Do you have to do behavior supports? When and why? These are some of those Q&As. I'm going to skip past them because they're all here and you can access them through that link to the PDF. There's another slide after that if you want to skip forward. Same questions, one more slide after that. And they're all from the same document. These are, again, same thing. The last slide is the one I wanted to kind of skip forward to, which is also some other helpful resources. Where do you find the information on the guidance and the law, Part 200 and 201 regs? There's a link to it. There's also some behavior and discipline procedures and guidance from the State Education Department. They have a whole bunch of different Q&As and functional, the FBA BIP. I caution you to note that those changes to functional behavioral assessments and behavior plans have to be looked at through the guise of, they haven't updated the electronic version of 201, but there have been changes to that because of the change in discipline and removal related to restraint, seclusion, and timeout. So if you're looking at those documents, note that you should still check against one of the documents also on that same page that talks about the changes to restraint, seclusion, and removal and physical restraint, because there's some minor changes, and we've eliminated prone restraint. You've eliminated the ability to physically restrain a student purely for the protection of district property. But there are limited authorized uses of physical restraint, and there is limited use of timeout pursuant to those regs. And then we just have the Q&As and a couple of other helpful resources. So the last slide is the questions, which is why I was skipping to the end, because I did see one or two, and I wanted to make sure that there was time for questions. So Steve, I saw 2 or 3 questions. I don't know if you saw that. And so I'm going to address them, and if you want to chime in, feel free. So,
I didn't see them, so I'll listen.
Okay, so they're in the meeting chat. So, hey, Kate, gotcha. So where do private schools share, where do private schools fall in with responsibilities in this process for disciplinary hearings and everything? Well, that's actually in that nice little FAQ where it talks about what is the role for private approved schools, or private schools in general. And in most cases, if it's a discipline that's imposed by a child attending a non-public, not private approved school, that private school will do that. We may still do our manifestation, but they're going to be subject to whatever codes of conduct the private non, approved school has. Your program is I know the person who asked the question. Your program is an approved private school, which means it's one of them that are still subject to, the special education rules and regs. Typically, the homeschool district will work with you to do the discipline hearing, the determination of a disciplinary change of placement, IAES. So that's really going to be in combination. So the private school provides a lot of the info, the public school will do the notices and the procedures, but that also means that you have to make sure that you're collaborating in a timely manner to make sure that they can get there. One of the questions that I skipped by on the FAQs is what happens if the manifestation team can't come to a consensus? That's in section F on the frequently asked questions, and it's one of the questions I highlighted, which is, if you can't come to consensus, the buck stops with the district. So ultimately, the CSE chair still has to make a determination. Our goal is always to reach consensus, but sometimes that cannot happen because there may be, splits between, is this the same? Is it manifestation? Is it not? There has to be a decision. You can't not have a decision. So if the team can't come to a full decision, there is still going to be a prior written notice issued. There will be a determination made, and then that determination is still subject to a possible challenge or review. How long can a student be kept in an IAES if they can't return to their original placement, but there's no alternative placement found? Okay, so an IAES is a term that we use in the context of discipline or a removal as a basis of hearing office. Other times, it is, we may have an agreement between a parent and a district to put the child on home tutoring or in a alternative setting as a measure while we are pursuing referrals and securing another placement. So it's important to understand the difference between a disciplinary IAES and an agreed upon change of placement. It's an IAES if that child was placed in that alternative setting and is receiving instruction due to the discipline process, either a principal suspension, a superintendent's hearing, a hearing officer removal, or that emergency removal, due to the continued threat to health and safety. Otherwise, the child is in a alternative education interim setting while we're making referrals. There isn't a timeline, but the problem with that is, candidly, we have a lot of shortages in programs. We have, the state is working on trying to get some new programs and get approval for some new programs, but it is still a process. And I think many of our BOCES programs are happy and willing to expand as soon as they can find the staffing to do that. It is not a lack of, we have kids that need to go there and we have even some spaces that are aligned. It's the staffing piece and making sure that, we can meet the needs of students that are being taken into those programs. That continues to be the process. What I am always fearful of is kids who are in a alternative homebound setting for extended periods of time. The longer you're out of the process, the harder it is to transition back. And so I think that if you have students who are on a longer term alternative agreed upon placement, there should be regular review of data. There should be discussion about what are we doing to really work on the skills that are impacting the student's ability to be successful or to return to a less restrictive program, and what other options or resources do we have to try to work together to find programs. Unfortunately, not every district has the ability or the capacity to create an in-district program. One, because there may not be any other similar, students with similar needs. And two, while I appreciate and understand parents most often want their kids to stay in their home district and not have to travel, the reality is that for some of the specialized programs that kids may need, they are going to end up traveling to another area or a private approved program in order to access them. The trade-off is they get to a program that has usually a much higher level of staffing and expertise and professional support. The challenge is you have a longer ride, and it may include some additional frustration. And so we have to figure out, how to make those pieces work. But I always remind people that IEPs are a constantly changing document. They change when the needs of the students change, and sometimes the students' needs will increase, and sometimes they will decrease. But we should always be looking routinely at whether or not the student is prepared to transition to a lower or a higher level of support, because that is our ongoing job, to always look at least restrictive environments. And when you're looking at kids with mental health challenges, that may rise and fall based on where they are on a given time. Kids who are, in a very stable place may, need fairly minimal supports. Kids who have had multiple hospitalizations and who've been, struggling to come back and not been successful and then been rehospitalized, our need review should be, upon their preparing to return, because they may not be ready to transition right back into school. They might do an intensive, adolescent outpatient treatment program on a half day. And so we might say, okay, do we have them do a couple of hours a day? Do we have them stick with tutoring? Trying to pair together and, collaborate with the parent, the treatment team and school to figure out how do we prioritize what the student's going to do? What do we need to do to make this work for the parent and the student? And most importantly, always keeping our eye on the long range plans, which is, what is our goal for this student? And if our goal is the student will be pursuing a regular high school diploma, we need to keep thinking about credits. We need to keep think about labs. You need to think about all of the pieces that they need to have in addition to managing the current crisis. And that's, where I always say the collaboration is the most important, but sometimes it's hard because, sometimes parents are concerned that they feel that the districts are asking for consent because they're going to talk about the parent or the student behind the scenes with the provider. Oftentimes, that's a misimpression. What really we want to do is make sure that, are you aware, these are the services and supports that are in effect with the district. These are the number of dates the student has missed. This is what we're seeing, so that they have both sides of the equation. Other times, the providers are happy to have that communication to say, we want to really work on, coming up with common approaches. And if you're doing, no negative self-talk, we can echo that in our in-school program. And if we're doing, just breathe or, calm and rational, and these are our approaches, having that similarity can be helpful in terms of making those determinations. So I just see a couple more questions, but I know that we're at the end of time. I'm happy to stick on for like another minute or two if people want to have, hang on for another few questions. But if you have to go, I totally understand and respect that. Ellen, if you want to drop the share
Yep.
screen, I don't think we need to have the presentation
Please,
up.
and
So,
please fill out the surveys. That really
oh,
helps
yes,
us. Please,
yes,
we
please do.
appreciate that. I can hang
Okay.
around a few minutes.
All right. So, would an official diagnosis of any mental illness or substantial mental illness be required during the manifestation for a student with significant behaviors? Well, again, we're gonna know what the student's needs are based on what's in the IEP. If we have after the fact, later breaking news or diagnoses that sometimes is not information we had at the time, that it might not factor into the manifestation at that point, but it still is going to be something that needs to be addressed and looked at as a longer term program. Because now that we are aware, if the district didn't have that information, you should be taking that under consideration, and you should be, programming and trying to address that. Sometimes we have a lot of diagnoses and some of them may be conflicting. And so we also may say, we may want to talk to the different providers or, even potentially, try to invite some of them to collaborate or to communicate with our school physician, just so that we can make sure that we have an understanding of what it is that led to that diagnosis and what their concerns are and what the district or the program is seeing, to make sure everyone has a consistent view of those needs. And again, there are also a lot of rule out diagnoses with mental health, and sometimes it's because the student hasn't demonstrated symptoms for a long enough period to meet the diagnostic criteria, but it doesn't mean that they're not still, experiencing some of those mental health symptoms. So the fact that they don't have the per se diagnosis doesn't mean that we'll say, well, sorry, no diagnosis, we don't care, we're not going to address those. What it might mean is we look at it and it may be part of our monitoring or our data collection. Providers may say, the child is taking a medication, it's to treat this, but it may cause other symptoms such as X, Y, and Z. Okay, what we could do at schools is we can, figure out what symptoms or signs you want us to look for, and we can report back to you and give you that information. And we can also give you feedback on whether we're seeing positive changes or negative changes. On the flip side, you may want to know what our teachers are, seeing, and maybe we do some additional rating scales after they have sort of hit that adjustment sweet spot and see if that, if we're seeing the same extremes or less extreme behaviors, that helps the provider know if their titration of medication or the frequency of treatment or the strategies that they're using are effective. I don't know, Steve, did you have any other thoughts that you
Yeah,
want to throw in?
I just think, the best practice is as soon as you have information, if you want help from the district, you should share it with the district. If there's stigma that you're having within your family, then we should talk about that and talk with your child and we'll figure it out. But that's just best practice to what you just said, I think, Tara. Just share as soon as you know. Otherwise, they're not really identified as having that problem, number one, from a legal perspective. But then two, like how is everyone going to help them? How is the school going to help? So I would just say best practice is inform as soon as you know.
Yeah, and I think that sometimes there is reticence about, well, how do I know what the information is going to be used for? And what if it includes like extensive family history that I don't want people to know about? There's still, schools are subject to confidentiality and all of the provisions that apply both under the Family Education Rights and Privacy Act, or FERPA, as well as, IDEA and 504, which both prevent, disclosure of information, and including personally identifiable information about, students with disabilities. And frankly, I think that most districts do a fair amount of training with staff to remind them that, information we get in the role of being a staff member is not information that should be, treated lightly. We do get a lot of personal information. Parents may share first with schools that, we're in the middle of an unfortunate, family just, separation or, a divorce. And we may know that, and sometimes they are still working on figuring out how to navigate that with their kids. So it's important to remember that information you have should be treated in the confidence in which it's given, and it's not, public disclosure or discussion. It is potentially relevant to make sure that we know how the child is, responding and how they're feeling and what kind of supports they might need. And, frankly, in some cases, particularly with kids with mental health issues, maybe when we know that we need to kind of go a little bit easy, and maybe we're not going to be calling on them first thing in the morning, particularly if we know they've been, bouncing back and forth between two different parents' homes. If they don't have their homework, this is probably not the day to dig in and say, okay, if you have it tomorrow, we can still, accept it. That's where I think that the collaboration and communication can be very helpful. And again, no one wants kids not to be successful. I think that, the importance of recognizing the mental health aspect is it is a part of our kids who are struggling with mental health issues, but it's not the only thing about them. They're still kids, they're still learning, they still have all of the, challenges that every teenager has, but we also want to teach them to manage, navigate, and to be productive. And so making sure that, we treat them both in terms of addressing their mental health needs as they exist, but also looking at it proactively, which is helping them accept and navigate how to handle their own mental health, acceptance, and then being able to advocate, because mom and dad are no longer, with them as they go off to college and into their jobs. And if we have failed to prepare those kids to be able to recognize not just, hey, I have a disability, but this is what I need and this is why I need it, and not just simply say I have a disability, so I'm not responsible. That's, you don't want that to be the mentality. And we have had some kids who are like, I have a 504 plan, I have an IEP, and you can't discipline me because I have ADHD. I was like, that's not quite right, but I'm glad you know, and I'm glad you understand that. Now let's talk about how we can, recognize that there are still good and bad decisions that can be made, but I'm glad that you understand that, disabilities do impact you and can affect your decision making. And now let's think if it did impact this one as opposed to all decisions, because, that's where I go, that kids with disabilities are just kids, and we all make good and very bad decisions at different times. I like to hope for the best, but that does not always work out. So we'll go there. All right. I think I've answered all the questions. Oh, mental health determinations, medical versus educational. The only other thing that I would say on that is, you know, the mental health determination, medical versus educational, it depends on what the district needs. Oftentimes we'll get notice from parents saying, well, I'm getting a new diagnosis, or someone told me that this is the diagnosis. It's hard until, you know, we have some documentation to that effect, because again, it might be, we give the diagnosis, but it's not written, or it's not, you know, it might be still listed as a rule out, which doesn't mean it's not a consideration, but it may mean that that's not a definitive diagnosis. And sometimes it does take a while, or the kid's too young to make that, you know, clinical diagnosis. So we're going to keep going. All right. I see that we are at the end and our poor petitioner has got to get going. So I cannot hold anyone hostage, but thank you all for hanging in and staying around. And please make sure you fill out your survey, and thank you for joining.
Thank you,
Thank you,
everyone,
everyone.
for joining. We appreciate it. And if you could fill out the evaluation and email me if you're interested in joining the task force, that would be awesome. I already see one email. Thank you all again, and we'll see you soon. Thanks, Tara and Steve.
Thank
Kat,
you.
you can just
Bye-bye.
call me if you have any other questions. All right. Bye, all.